I'd like to invite our first speaker up. Susan Tansey Pfeiffer is the Director of Cardiac Services. She's in Morristown Medical Center in New Jersey. I'm sure I botched that there. And she'll tell a little bit more about kind of her, where she's been, and will start things off for us with a topic of if we build it, they will come, talking about right-sizing your program. So come on up. And please welcome her.
Thank you, Liz. Thank you all for being here today. My name is Susan Tansey Pfeiffer, as Liz said. I'm the Director for Cardiac Services at Morristown Medical Center. Prior to that, I was the administrator for the VV ECMO program and the cardiogenic shock and VA ECMO program at New York Presbyterian Columbia University Medical Center. Sorry, a mouthful. So my hope is to talk to you a little bit about this topic today. If we build it, will they come? And the considerations you should have when you think about whether or not you want to start an ECMO program. And I hope to offer you the unique experience that I have building both an academic medical center-based program as well as a regional medical center-based program, and how those different experiences, very different experiences, allow me to, hopefully will give you some insight into those. So as Liz said, ECMO is a hot topic right now. The COVID pandemic has definitely pushed people into starting an ECMO program or interested in getting into an ECMO program. But for those of you who are here, I think we're all believers, and we know that ECMO saves lives. We know that ECMO's done some amazing things, taking people from the brink of death to live thriving, wonderful, long lives. And that's why we want to continue doing that. For those of you in finance in the room, I know you know that ECMO actually makes some money. So it's a very exciting thing for people who are interested in the finances of ECMO. So up at the top, you'll see, up on the slide, you'll see what the national Medicare rates for ECMO are. And these are the published rates for 2022. So as an MSDRG reimbursement, ECMO can make a hospital per patient about $140,000 per patient. For physicians, there's reimbursements that you can get for cannulation, for initiation of the ECMO circuit, daily management, removal of the ECMO circuit, repositioning, which I don't think I have up there. But these are the Medicare rates. These are pretty low rates, the lowest that you'll probably get in the hospital. So if you have commercial payers, you'll see 2 to 3 times the amount of reimbursement. So that's really enticing. I'm here to tell you that's not the reason to start your ECMO programs. ECMO is obviously much more complex than just putting in cannulas and discharging patients. If it was not complex, everybody would do it. So we want to make sure that you're creating really great and high quality ECMO programs. And my hope is to give you some insight into 3 things that I think you should think about when creating an ECMO program. One, oh, we're stuck. Okay, I'll keep going. Okay, there we are. So 1, having the right team. 2, having the right tools. And 3, having the right patients. These are the 3 biggest considerations you need to make. And within that, they're all, I'm just going to put this down because it's shaking and it's bothering me. So these are the things that we all, they're much more complex parts of it, but in 15 minutes, I'll try to summarize all of my thoughts associated with these things. So an ECMO team is a pretty big team. There's a lot of people. When you have a high-quality ECMO program, there's a lot of people involved with these patients. If you're thinking about starting an ECMO program, a good place to start is with your hospital leadership and administration. Those are the people with the money. So, and you need some money, you need resources in order to start an ECMO program. So I would make sure that they are people who believe and want to invest in what you do. And that's a really great place to start. The second thing to do is to make sure you have really great internal partners. Your internal partners can make or break your ECMO program. So if and lots of those people are listed here: cardiology, pulmonology, nursing, perfusion, critical care, social services, PT, OT, all of these types of, all of these people really, they touch ECMO patients. They really need to know, they really need to be part of your program as you develop it, and you really need them. So making sure that they have belief in your program and they're willing to dedicate the time and the resources it needs to build your program is very important. Now, when you talk about your team, you want to think about this advancer really is tough. When you talk about your team, you want to think about your model. And I know this is a big question. When I worked in New York, we got calls every week. What's your model? There's surveys that go out everywhere. So, are you going to have somebody sit bedside? Are you going to have somebody remote inside the hospital that's managing while you have maybe a bedside nurse kind of keeping an eye on the patient? These are things to consider because they all require different amounts of investment of time and money. And they also require training. So if you are having perfusion sit bedside, that's pretty good because the perfusionists are experts in what they do, and they probably don't require a lot more training. But you do want to think about, for anybody else who's around ECMO, having a baseline understanding of what ECMO is very important. And so you want to consider that training should happen even at a baseline level for nurses, for APPs, potentially residents, providers, physician providers, and things like that. Anyone who interacts with ECMO may require some type of training. And that training costs money, and it's not a one-time thing. So if you don't have a large volume of patients, for example, I went from a hospital that had over 250 cases a year to a hospital where we're seeing 7 cases a year. If you're not seeing that volume all the time and those types of patients all the time, the training is going to be really important, and it's going to have to happen pretty frequently. Even at Columbia, we would train people, we would have an initial training, and then we would have people come every 6 months to have a refresher on emergency management, because we had a remote program where people were in-house rounding on the patient that were the ECMO specialist. But those people at the bedside, they needed to know. If there was a problem, they needed to know how to respond to it, and they needed to understand that. So when thinking about what your model is, think about how much you're going to invest in the training associated with that model. So the team obviously is extremely important. Devices and destination. This is another important investment in your program, and partly related to devices, especially related to what your model looks like. So if you're going to be transporting patients on ECMO, you need a device that can transport easily. That's something that I got to my recent hospital, and it's a regional medical center, and one of the first questions I asked was, can this device that we have, that's not a box, which is what I was used to at Columbia, can this get on an ambulance? Because if we're going to send a team out, we need to make sure the team, the device, and maybe associated, because we're mostly a VA program, so it's very likely we would have a balloon pump or an Impella that's also on the patient if we're transporting on ECMO. The reason why I asked that was one of my first questions is because I know that Saturday night at 2 in the morning is when people like to die on us. And so I wanted to make sure that when that call came in, I had an answer to say, to my physicians who are going to say, I want to go get the patient, whether or not we can get that device on that bus. And the answer was we simulated it and we couldn't. Now the question came to me, well, should we buy devices that are smaller and more transportable? And my answer was, how many times a year are we really going to see a patient that can't be transported without ECMO? I don't think in this hospital system we're going to see a lot. So maybe it's not worth the investment in that, and maybe we just tell, if a patient really can't move without ECMO, we call it out to a center that has a transport program. So really consider those things, because one patient, even though that patient reimburses a lot of money, that patient can cost a lot of money. And we want to make sure that those costs are not exceeding your reimbursement. So devices, super important. If you have a remote model, if you have people rounding in the hospital that are your ECMO specialists, you may want to consider a device that's a little bit, that has a little bit more bells and whistles, that maybe warns the bedside nurse when things are going awry, or the bedside provider. Those are kinds of things you may need to consider. It costs a little bit more, but maybe, and so you're having more training and, now a higher priced device, but you may have better safety for your patients, and it may allow you to see more patients if you can move your bedside specialist away, or your ECMO specialist away from the bedside. So really important considerations. In terms of destination, I can't emphasize this enough. Not every patient recovers from ECMO. Many of you who got into this business during the COVID pandemic probably got a rude awakening very quickly. Even the young patients we found did not always recover from ECMO. So before you put a patient on ECMO, it's really important to think about their destination if they cannot come off the circuit. And if you're an institution, so the hospital I'm at as a regional center has a robust cardiac surgery program. We have LVADs in-house, but LVADs are not always the best answer to the question for a patient whose heart is not working anymore. It's not a really long-term device, so heart transplant is usually a better answer for patients that are candidates. What we've done is developed a relationship with a hospital that has a heart transplant program. And I'm not saying, we don't do a lot of VV ECMO at the current hospital, so they do lung transplant as well, but we would most likely, if that patient needed ECMO, send them out to begin with. So ensuring that you have devices and destination therapies that are available, or at least a plan to get these patients to a destination therapy, is really important. And from a financial perspective, it's also important, because if you have a patient that doesn't have an exit strategy, they stay in the hospital for a long time. And if you don't have a good palliative program, which I listed at the end there, to help the patient get to a place where maybe you withdraw care, or the family get to a place with you withdraw care, the patient's on ECMO for a long time. Every day a patient is on ECMO, that's cutting out of the profit for the hospital. So if you have a patient that's stuck on ECMO, it's going to be a problem for your profit. So it's also not the right thing to do for the patient, and it's also not the right thing to do for your team. So something to also keep in mind is that when we go back to that team, you want to try to choose patients that are going to do well, especially in the beginning, because what you don't want is a team that's burnt out, that says every patient dies on ECMO. And that's something that you really should consider. So important to understand when you're putting a patient on ECMO what that trajectory might look like if they don't recover. Okay. So my next slide is about patients. So if you build it, will these patients come, and where do you get them from? So patient volume is important for many reasons, both for profitability, for quality and familiarity of your staff, and building that knowledge with your staff. And one of the most important things to think about is your patient selection when talking about volume, because it's very easy to say, oh, we want to just put patients on ECMO. I'm going to tell you a little story about the center that I work at now. Before I arrived there, they had consistently about 25 cases per year, and ECMO was exploding. They could not manage the number of patients that needed to be on ECMO. And that 25 patients a year started about 2 to 3 years ago. Maybe some of it was COVID pandemic, but it actually started even before COVID. When I got to the hospital, and since I've been there, we've been there a year, I came over with 2 physicians, so we came over as a team. They thought the ECMO was going to explode even further. As it turns out, we've only had 8 patients on ECMO since I've been there in the 1 year. The reason is that of the 25 patients they were putting on ECMO, 63% were dying. Of those 63%, most of them were dying within the first 24 to 48 hours. Patients, so ECMO, not everybody, I think, for those of you who know Dan Brody, he always says, not every patient needs to die on ECMO, right? And that's something that I think is really important and resonates with us, is that we make sure that we're choosing the right cases, the patients that have a chance, the patients that have the opportunity to recover or go for an advanced therapy. And that's something I think you really need to consider when you're putting patients on ECMO, and how to generate your volume. Generate the right volume, don't just generate volume. When you have a standard selection criteria, which I hope each of you develop, I think that it's really, really important to think about whether your patients are coming from internal sources, external sources. So when I was in New York, patients often didn't get sick enough to need ECMO because we were at an academic medical center and the care was excellent. Many of our patients actually came from referral sources outside hospitals that were referring in. we had to, in some way, market ourselves to those hospitals. So considering a plan for getting the word out. If you're a medical center that's part of a hospital system, both internally and externally, you need to understand who your partners are. So internally, the ED, other ICUs, they're your partners. They need to understand, one, what they're looking for in order to refer a patient, and two, what your process is to get those patients to you. If you have a transport team, the transfer center needs to understand that when somebody's calling about a certain type of case, that's an ECMO case or potential ECMO case, and how to get to your program. So those are the things that you should really consider when you're determining what your catchment area looks like. Now, with regard to your catchment area, you already have referral partners. They're usually people within your community, either internal in your hospital or outside of your hospital. What I learned in the regional medical center is that even though we gave the criteria, we talked to people about our program, we told them how to get to us, many of our referral partners are private practice-based. This was new to me. I worked at a medical center with intensivists who were always sort of like in the hospital and working with patients and that they didn't really know. Private practice physicians function a little bit differently. They like to hold on to their patients. These are patients they've known for many, many years. They often don't want to give them up because they feel like if they transfer them to somebody else that they're going to take those patients and they're never going to see them again. And obviously volume is really important for referral partners. So one thing to really consider is how you develop a shared care model and how you market that to people. You need to determine or to let people know that you're going to take these patients in their acute phase, but then you're going to send them back for the rest of their care. Follow up with them, give them the update on how the patients are doing. And remember that not all of your referral sources are going to be physicians. So what I learned in this regional hospital is that some hospitals don't have attending staffed at night. And so nurses are really the people at the bedside, and they're usually working with residents who come in and out. So making sure that you're marketing not just to physicians, but to the people who are actually in the hospital, APPs, RNs, those are really important referral sources, and following up with them. Because when people hear success stories, they think about sending more patients. So making sure, and if it's not successful, you can actually teach them what went wrong or what maybe to look for a little bit differently next time, or when to call a little bit, or to call a little bit earlier. So those learning opportunities are really important when you're building a new program. And finally, I just want to talk about competition and your catchment areas. So things to consider is, how do you get patients to your hospital typically? What is your geography? Are you sending patients are patients coming in via helicopter? Are patients coming in via ambulance? Do you need ECMO to get these patients to you? Or can they come by some means before they're on ECMO and you're cannulating at your hospital? Also important to consider the competitors in your area. In New York, there's tons of hospitals that do ECMO, tons of hospitals that transport ECMO. There's one hospital for 445,000 people. So there's a lot more patients that have the ability to get sick in New York. So you can have lots of competitors, and everybody sort of gets a piece of that pie. In New Jersey, we have one hospital for 49,000 people. Our catchment area, even though it's pretty large, and we have 4 hospitals that feed into us, we're losing ground to a lot of hospital systems. So once a hospital joins a system, they usually have to refer within that system. They can't really refer outside of that system. So if you had referral sources before that are now joining another hospital system, you may lose that source. So consider that when you're thinking about your program and you're thinking about your referral sources and who you're marketing to, and ensuring that when you take a look at that your referral sources are going to be robust and that you're going to keep in touch with them pretty frequently, because someone may send you a case today and then you don't hear from them from a year from now, but sometimes it's just that they forgot, or they didn't have the people at the center who have the knowledge about your program. So my timer's not working. I'm sure I'm over, but I really enjoyed giving this talk today, and I just want to leave you with a couple of really important takeaways. Make sure, one, if you're building an ECMO program, it's for the right reasons, not all financial reasons. I'm an administrator, but I always make sure that we're doing it for the right reasons. Make sure that you have the right team in place, make sure that you have the right tools in place, and make sure that you have the right patients in place. Always do what's best for the patient and what's best for your team. I appreciate you being here today and inviting me up to talk. If anybody has additional questions after this, here's my contact information. Please feel free to reach out to me. I'll be around during the networking event and after the panel. So I look forward to hearing all about your ECMO programs and how we might be able to help build them. Thank you.
All right, so next up, I invite Dr. Joe Tona. He's at the University of Utah in Salt Lake City. For ELSO, he serves on the Scientific Oversight Committee and Registry Committee. So for those who have tapped into those resources, you may have bumped into his name via email. So we gave him the topic of EC yes or EC no. So kind of going into indications, contraindications of selecting patients. So it is all yours. Thank you.
So, EC yes or EC no, indications and contraindications to ECMO. So, as you start to develop your program, or if you already have a program, you realize that you're going to start to have a reputation around the hospital. People are going to start to know you as the ECMO person. And they're going to start to come to you with questions about who should go on ECMO. And some of these questions are going to be very benign. They're going to be questions where they're just kind of curious in the future when somebody decompensates, they have a bad aspiration, should they put this person on ECMO? And other times, the questions are going to be a little more concrete, where they have somebody they're currently taking care of, and they're wondering if they should be considering ECMO on this person who isn't doing well. Other times, you're going to get someone who's going to come to you who has really strong feelings about ECMO. They either believe that ECMO saves everybody, or they think ECMO kills everybody. And they're going to come to you to start a fight, just to kind of validate what they're thinking or to get you to disagree with them. Either way, you're going to be in a situation where you're going to hear some stories where you're like, this is a really great patient for ECMO, let's get them on. And other times you're going to hear something and you're going to hear about the 90-year-old with renal failure and metastatic cancer who's got the intracranial hemorrhage and now currently has acute cardiogenic shock. And they want you to put this patient on ECMO, and you're thinking, no, this is not going to go well. So I'm going to help you navigate this a little bit. So these are my disclosures. I work at the University of Utah. I'm an intensivist and an emergency physician where I run our ECMO program there. I also have a grant from the NIH to study ECMO patients, and I'm the incoming chair of the registry committee, as was mentioned. And so all the images that I've used for these slides I've taken right off of Google. So now you've got your ECMO program up and running, you've got your circuit, you've talked to all your partners, you've got your cannulators, you've got the people who are going to be taking them off ECMO, the people who are going to be closing the arteries, you've talked to your vascular surgeons who are going to be dealing with your complications. You've talked to your general surgeons who are going to very kindly deal with your abdominal complications. Your administrators are on board, your nurses are trained up, your specialists and your perfusion team is trained up. And now you've got a hammer and everything looks like a nail, right? So you've got to figure out who you're going to put on ECMO. This is true. So I have been doing ECMO for a little over 10 years or so, and I have made a lot of mistakes. And I've learned a lot from those mistakes. And I wish that there were an easier way to learn. I have called many mentors and people whom I trust to get their advice on difficult cases, but I've still made a lot of mistakes. And the benefit of that is that you get a lot of experience from that process. So, who should we put on ECMO? Basically, you have three types of ECMO. We have VV, VA, and ECPR. And every time I want to put somebody on ECMO, I ask myself two basic questions. One, am I prepared to take care of this patient? And can I get this patient off ECMO? And when I say can I take care of this patient, what I mean is that putting patients on ECMO is just a temporary therapy. It's not the cure. ECMO is never the answer. It just buys you time. And so if I put somebody on ECMO who has lung failure, many times I just have to continue doing what I'm doing, mechanically ventilating them, using antibiotics, good fluid management. There may not be anything else I need to do. But if it's pulmonary hemorrhage, I might need to take them to interventional radiology. I might need to get a thoracic surgeon to intervene and take out a lobe. There may be other therapies that that patient needs while they're on ECMO. If it's VA ECMO, say they ruptured a mitral valve. Putting them on ECMO may help them, but it's not going to fix the problem. They need a cardiac surgeon to fix that valve. Say they had a STEMI. You can put them on ECMO for the biventricular failure or the LV failure, but you still need to fix that STEMI. So this is the thing I'm always asking myself when somebody is in a situation where they might need to go on ECMO, is what's the therapy they're actually going to need to get better? Because the ECMO is just going to get me a little bit of time and bring some complications with it, I can assure you. It's really the therapy that they need. So I mentioned this, if they're on VV ECMO, it's often just time that they need. But if they're on VA ECMO and it's cardiac failure, they might need PCI, they might need surgery, they might need a VAD as a way out. Then there's ECPR. I love ECPR. I study ECPR. But I'm going to say that I would encourage you to not start a new ECPR program until you have an established ECMO program. And not everyone will agree with me on that, but I believe that people should first cut their teeth on ECMO, VV, and VA before you start doing it on dead people. Because not only with ECPR do you have the difficulty of having to cannulate somebody who doesn't have a pulse, which is very difficult, but you then also have to do something to reverse the cause of the arrest. And in my experience, nobody goes on ECMO, nobody arrests because they needed ECMO, right? They arrested because something went drastically wrong. And that drastically wrong thing might be something like a STEMI. That's relatively easy to fix. It's identifiable. You have to do it very quickly and with a skilled team, but it's a discrete problem. Other people arrest because of, insidious hypoxemia, hypercarbia. By the time their heart stops and somebody recognizes it, they've already suffered a profound period of hypoxemia that might lead to a neurologic injury from which they can't recover. So at the moment somebody really, ECPR is just, they should have been on VA or VV a long time ago, and then something went wrong. So you have to remember that not only are you dealing with a technically more difficult cannulation for ECPR, and I have caused a lot of complications, but you also then have a situation that you have to reverse that may not be something that is easily reversible. You might have to call our next speaker, Dr. Bartos, here and get his mobile ECMO team to come on out and take care of you. So when people ask me, what is the indication for ECMO? I answer with this every time. The indication is acute, reversible, refractory cardiopulmonary failure. And if it doesn't meet all of those criteria, it's not a good patient for ECMO. You don't want to be putting patients on ECMO who have chronic problems that have then decompensated to the point of being an end organ failure of the heart or the lungs. You're not going to fix that problem on ECMO without transplant or some sort of mechanical device. Same thing with it being reversible. If you have an irreversible problem, you're not going to fix it on ECMO. So you have to know what's that path off before you go on ECMO, because otherwise you're at that bridge to nowhere situation where you've got them on, as our previous speaker said, and now you don't have a way to get them off. And refractory is the idea that you should really be optimizing medical management first. I've seen a lot of people who go on ECMO really early in their disease process, and sometimes that goes okay, and sometimes they end up with a head bleed. And so I would encourage you to really ensure that you are putting patients on not too early and not too late. You have to find that sweet spot. So for respiratory ECMO, questions that I often ask myself are, what's the etiology of the respiratory failure? How long has it been going on? And specifically, how long have they been ventilated for? And then what are concomitant organ failures that this patient is experiencing? It hasn't played out in the scores, but I find that when patients are not in renal failure, it is much easier for me to manage their fluid status on VV ECMO and then get them dry and get them off than if I have to do it through a CRRT circuit. Likewise, we know that patients who have been intubated for more than 7 days, mechanically ventilated, do much worse than those who have been intubated for fewer than 7 days. We know that the best outcomes are for people who've been intubated for less than 2 days. So although it's kind of a pie-in-the-sky goal, is you really want to take the patients who are going to go on ECMO and put them on right away. So you have to kind of predict the future of, is this person going to need it? You don't want to sit there and say, let's wait and see for 5 days what they do. We can go over some of the hard criteria that we say for ECMO, and I will give you an example of where you can look for this. But traditional criteria that have been used in randomized clinical trials have been a P to F less than 80, or refractory acidosis despite optimal ventilator management. So pH of less than 7.25 with a normal CO2. And what I'll direct you to is this is one of the guidelines that ELSO has put out a bunch of guidelines over the last year, and this is the one for VV ECMO. And we try and detail in here what the criteria are. But broadly, the reason why I've been talking as opposed to just listing what they are is that I want you to walk away with a sense of conceptually what to think about that you can then apply to the diversity of clinical situations that you're going to come across, as opposed to a set list of yes, no, yes, no. Because every time a clinical situation varies, those criteria may not work real well. As I said, ECMO is nothing more than a bridge. And so you really want to have a good sense of what am I going to do to fix the organ failure, and then how am I going to get them off? You want to answer those questions before they go on ECMO. And so the way I find this actually plays out is, as I said, I run the ECMO program at the University of Utah, and I'm probably the person who says no the most, because everyone comes to me and says, I want to do ECMO, and I'm like, this is not a good idea. Because I anticipate what's going to happen 2 and 3 and 4 weeks down the road. I don't just see the moment right there where we put the person on. I work in the ER also. The ER loves putting people on ECMO, right? And I'm like, why are you putting this person on ECMO? This is not going to go well. So really, I'm probably the anti-cheerleader for ECMO, but I'm a realist. So who do I like to put on ECMO for respiratory failure? Hantavirus. Hantavirus is fantastic on VV ECMO, right? They get really inflamed for 2 or 3 days, their lungs completely white out, then you take them off ECMO and they're fine. Hantavirus is a great one. Who do I not like putting on ECMO? Really bad end organ lung disease, ILD, COPD that then decompensates. That's not going to go well. Once you fix the decompensation, they've still got the end organ disease. So these are some of the scores that have been developed over the years to try and predict outcomes for VV, VA, and ECPR, to try and give clinicians some sense of what to do for a given patient in front of them. And there's other scores out there. They will be updated, but there are scores out there to help you make a decision for each type of patient. So then for cardiac ECMO, some of the questions I ask are, what are the baseline function of the heart? Because if they went into it with an EF of 50%, it's likely that they're going to be able to come off with something close to that if we haven't made it worse in the process. If they go on with an EF of 20% or 15% or 10%, 10% doesn't do real well without like a transplant or a VAD at baseline. Like 10% is really quite bad. And we have patients who are at 10% and they go on ECMO, and it's like, guys, what are we doing here? What was the insult? So was it a univentricular MI? Was it biventricular? What are the therapies and interventions that we're going to have to do on ECMO? And then what is the expected recovery for this patient? So things that I think about is that if they have a STEMI, did that STEMI cause complete infarction of the heart where I'm not expecting recovery? And if so, was that the LV, where I can potentially bridge them off on a VAD? Was that the RV, where with time I can just get them to kind of a passive flow state? Was it biventricular, where I really need to transplant that patient? So these are some of the things I ask. Likewise, before they go on ECMO or when they go on ECMO, is the heart beating effectively? Is it ejecting? Are they pulsatile on ECMO? As soon as we take away that preload flow, do they still maintain the ability to open their aortic valve? Because if they don't, they need to have something in there to augment their pulsatility so that they don't clot off their LV. Do I have that ability to then put in a concomitant Impella or a balloon pump or increase ionotropy or put in a surgical vent? So these are some of the other things that immediately need to be done. One of the ways I think about this is with patients who end up going on VA ECMO is I'm often in touch with the cardiac surgeon, because if it's non-operative cardiogenic shock, I may need that cardiac surgeon on board to help me manage this patient. Whereas if this is somebody who's post-operative from CT surgery, I've already got them on board because they're kind of committed to that patient. So these are some of the things that you might be treating: pulmonary hypertension, myocarditis, bad multi-vessel disease. And you may need therapies, as I said, like VAD or transplant to get them off. These are some of the things that I consider as just easy relative contraindications to putting people on ECMO for VA. Likewise, we have some guidelines from ELSO that were just published this year that help detail some of these things in more granularity than I've offered in this talk. And I'll stop there, just a few minutes over. So thank you very much. That's my email. I will be around also up here. If you have any questions, please ask. Thanks.
All right, thank you so much. We will round out our first session with our last speaker here. So I'll invite up Dr. Jason Bardos, who's joining us from University of Minnesota, who will be talking, hopefully showing pictures like you just saw of the cool ECMO toy that he has in the form of a very nice mobile ECMO unit. So ECMO on wheels, considerations for ECMO transport, and share his wisdoms on what they've been doing up there. So come on up.
All right. Well, thank you very much for having me. Until we get to the point of teleportation, we're going to have to deal with the wheels part of this. And so I'll talk a lot about transportation of people for ECMO and transportation of teams for ECMO. And there are multiple facets of this, which I'll touch on from the multitude of sides here. So the first thing is a philosophical point, and that is that really the quality of your healthcare shouldn't depend on where you live. And this is really the foundation for transport programs. You're going to take a resource that is well-tuned and refined at your local hospital where you're working and you've built your baby, your program, and now you're going to take that out to people further away who otherwise don't have access to this. And there are two components to it, is how do you take it out, and also make sure you own your program, that you are very secure and critical of your program so that you build it to be the best program you have, so that when you take it out, you're providing the best care you can. Here I show you a 30-minute radius around the Twin Cities, so it encompasses most of Minneapolis and St. Paul. And the reason I chose 30 minutes is because I do primarily ECPR myself, although our program does all three modalities that you've heard about already today. But when you're thinking about ECPR, you have about a 30-minute transport window to get the patient to you, which again tells you the vast majority of the people that live in your areas that don't have access to this therapy. And if you look at the state of Minnesota, it's this tiny little circle in the midst of a big, tall state. And if you look nationally, that's from the ELSO website, all those little pins are programs, but there's these huge, vast areas with no programs near them, and certainly not within a 30-minute window. So while we may, in the state of Minnesota, cover about half of our population in the Twin Cities, half of our population is outside the window of any classic ECPR program ability to drive the patient to the hospital and put them on ECMO at that hospital. So the only way to really rectify these disparities is to take, again, the program to them. There are multiple ways to do that that have been being done right now across the world. to expand that. And when you think about expanding a program and taking it to the patient, you want to think about a few different ways of dealing with patients in ECMO. So the first is, again, bring the patient to the ECMO center. You may do that before, like I mentioned, that 30-minute window for ECPR. You may do that before they're on ECMO. For VV ECMO or VA ECMO broadly, you may have a larger window. It doesn't have to be 30 minutes. You may be able to transport that patient across the state before they need VV ECMO. So you can think of a broader circle and catchment area for that type of modality. You may also cannulate those patients at the site where they are currently receiving their care and then transport them on ECMO. And for those of you who have not done that, when you do that, you will recognize the multitude of complexities and complications that can happen when you need to transport a patient who's already on ECMO with all the accoutrement that that brings. The second way is to bring the ECMO to the patient again, so you can do that by sending a team. And these 3 different pictures are 3 different ways of doing that. So you can follow the Netherlands model, where they now have a countrywide model where they send a team out in a helicopter with ECMO circuit and equipment. You can do it the Paris model, which they've been doing for years. They drive out, they will put somebody on ECMO in the streets, in the subway, in their homes. Or you can do it in the Minnesota model. You've already seen one picture of our truck. It's about a foot longer than a city bus. It's essentially a mobile cath lab. So we can drive up to somebody's front yard, bring the patient in, load them in the back of the truck, and put them on ECMO there. That's meant for ECPR, again, for us. So when you're thinking about which of these modalities, which of these methods you're going to use, you want to think about the area you need to cover. For the Netherlands, they wanted to cover the entire country. So for that, they needed helicopters. For us, we started smaller. We started with a state metropolitan area, hence a truck. And Paris was dealing with traffic, so they brought everything to the patients and brought the team again in the streets and in the subways. But if you're not emergent, but instead you're urgent, you may be able to use a different process and again, use a more traditional transport means to get the patient to the ECMO or the ECMO to the patient. So planning is critical. And there are 4 aspects to the plan that I would encourage you to think about. First is the cannulation team. So you need a cannulator. If you're going to travel to the patient, you need somebody who's credentialed to cannulate in that location. If it's the street, happily no credentials needed. If it's a hospital, they need credentials, maybe emergent credentials that you can get en route, but it's still credentials. So you need to have that figured out ahead of time. Typically, there's some sort of cannulation assistant, maybe a trainee. That's a great opportunity for a fellow or resident to get involved. It may be a specially trained nurse or tech, somebody who knows the procedure, who can anticipate the steps and the equipment, and can help with the procedure itself. You also need an ECMO person, a person who's going to run the machine for you. And that's often a perfusionist in these models, but it could be an ECMO specialist, could be other people as well. In our situation, we use specially trained flight medics and nurses that we've trained on top of some ECMO training that they also receive. You need to think about how you're going to activate your team. Are you going to send out pages? Are you going to use phone calls, a phone tree, et cetera? And what is their expected response time? If it's ECPR, they have minutes to get to where they need to be, where the patient is. If it's VV or VA ECMO, again, more broadly, they may have a half hour to think about it and have a cup of coffee before they come in to do what they need to do. Second component is transport teams. So after the team has done their work, the patient's on ECMO, they're stabilized. Now you have to get the patient to the ECMO center, your center. And that transport requires some special training. If it's going to be ground transport, specially trained critical care medics are great. If it's air, some flight crews with special training for ECMO in particular is wonderful. It doesn't mean you don't send along a perfusionist or a physician to accompany them, but everybody in that team being specially trained goes a long ways. And you need to think about the turnover of that team or the availability of that team. If you're flying by air, the FAA has some flight time rules and duty hour rules that you may run up to, and so you have to anticipate those times of transition between pilots and their availability to provide the resources you need to get patients from point A to point B. Third category is equipment, and I think of equipment broadly. So when it comes to equipment, fixed wing, rotor wing, aircraft. It's great to have a system with a plane. Do you have 2? What if they need to do maintenance? Because in the end, your system, your transport system, is only going to be as reliable as your weakest component. And if you only have one plane, and that means that your program is shut down for the week or 2 or 4 that plane is receiving maintenance every year, then you're going to have to say no to programs when they call you. And that is devastating to a program. So think about the backup plans. And that impacts your distance that you can cover. Planes, of course, give you further distance than rotor wing or helicopters. But at the same time, often there are fewer of them. Availability of helicopters and the weather, whether you can fly in the weather of your area. In Minnesota, we have a variety of seasons. It's not all winter, but it is sometimes winter, and it is also sometimes storming and thunderstorms in the summer. And so we need to think about whether we can fly a good chunk of the year. Then there's the rest of the equipment, the packs that you need to bring, the cannulas, the ECMO machine. As was mentioned earlier, you do need an ECMO machine that's highly portable. Ideally, one that gives you feedback with respect to as much data as you can gather about that patient in the machine itself, so that you can easily transport a patient and know something about their status as you're transporting. Then the packs in the again, cannulas and other equipment, highly portable, packed in contained containers or backpacks, and checklists to verify that everything is there. You sort of have to think of yourself performing wilderness medicine. If you don't have it, it doesn't exist for your procedure. And so you need to make sure that you're verified twice or 3 times that everything is in fact there and ready for you when you need it. And the last thing with respect to planning is a planned, deliberate debrief and quality improvement process, because you're not going to be perfect the first time, you're not going to be perfect the 10th time. You got to be able to improve, and that means going through cases with your team to make sure that everybody understands what happened, good and bad, and can improve. Now, this is even once you figured all that out, I still suggest you need a moment of introspection before you start. Because you can have the best plan in the world, but if you don't have an ICU bed to put that patient in, you haven't done anybody a favor. So you got to make sure that you have ICU capacity. This is something that's near and dear to my heart after the last couple of years. Make sure you have a place that you can put these people. Which modalities are you planning to actually do? What is your sweet spot for your expertise at your center? Do you already do VA, VV, and ECPR, or do you only do some of those modalities? Again, I wouldn't transport what you aren't doing well at home. Own your space and bring your space out. Don't try to do something new out there that you're not doing at home. Do you have staff for transport? It's one thing to have a cannulator on call for your home institution. Now you've got to have somebody who can also cannulate and go and transport out. This is going to double your needs, obviously strain the logistics. And what transport modalities do you have? Again, fixed wing, rotor wing, etc. Okay, all of that is set. You've got the best plan in the world, and you've got the system that can handle it. Now you need people to call you. So, as was mentioned, referrals come from relationships, many of them already built. These are referrals, referral bases that you have for other things in your hospital, and now this will be one more population that they call you for. So the key thing here is delivering or developing a system that you can deliver, and delivering on that system every time. So a hub and spoke model with a reasonable distance of your spokes, making sure you can get there in time and get back in a way that maintains the stability of that patient. A streamlined system for calls, those referrals, ability to call in, get to you right away. These are the most critical patients that hospital, that referring facility is going to see that year. They need to know that you're there to help them and to basically dig them out of a hole. You're there to help that patient they don't have a plan for. So you need to get them to that reassuring voice as soon as you can. Define those patient selection criteria for them ahead of time so they can anticipate who they should be calling you for. And when you receive the information, you are predictably saying yes. If you're following the criteria, they will feel good about calling you. And then I say, follow the criteria plus, and that there is a gray zone. As you heard just in the previous discussion from Dr. Trona, there's a middle ground where you have these patients that fit the criteria or might not, but they're close, and there's some extenuating circumstances. Maybe they weren't on the vent very long, maybe they had a very short CPR duration, but they don't otherwise fit the criteria. And if you are taking those few extra patients in addition, they feel like you're advocating for their patients as much as they are, and they will latch on to you like nobody's business. So try to be extra generous in your criteria, but again, follow your criteria. Don't say no to people that your criteria say you should say yes to. First and foremost, after all these things are defined, education is critical. The more you teach the facilities that are calling you, the more attached to you they will be, the better patients they will call you for that fit your criteria, and the better they will take care of them for you in the lead up to handing them off to you. So really, cannot say enough about reaching out and doing education with all aspects of their team, the nurses, physicians, administrators. Leave no stone unturned. Everybody can be taught. Follow-up is the way to reassure those or re-solidify those bonds, rebuild those bonds after the case. Let them know how the patients did and make sure that they know that they were appreciated. They did a great job getting that patient to you as soon as they did. And then lastly, again, just keep in mind, are your outcomes where you need them to be for your program? They're probably going to take a bit of a hit in the world of transport. And also now that referring facility is going to be looking at your outcomes as well. So you want to make sure that you've done everything you can to solidify your program. Okay, there are still two broad paths for these patients, and you really need to realize that they do hybridize. So you may have a ECPR program where they ship them all to you right away, and you cannulate them at your hospital, where they may still cannulate a VA or VV ECMO patient and send them to you cannulated. But still, you can think of them as two broad categories. So the referral of patients for cannulation. These are patients that are transported, again, for cannulation, or cannulators travel to the patient. So they're asking for help with even the cannulation step. Again, here you want to educate them on patient selection and then that emergency credentialing process so they can help you on their side as well. Your transport's going to have to be fast because the patient's not stabilized till they're on pump, and they need you to help with that process. So you need a very rapid activation process and transport process. And then follow up regarding those cases. And you may have a little longer time to cannulation, so again, you want to solidify that process to get the cannulas in as quickly as you can. Then there's the cannulation and ship model. They have cannulators, they're going to cannulate, and then they send them to you. Here, the big hang-up is guarantee of patient acceptance. The last thing they want is to cannulate a patient and have nowhere to send them. So you have to be very clear with them that if they cannulate someone, you're going to take them. And oftentimes, these centers, at least in our world, will call us for permission effectively before they cannulate, even though they have all the skills to do the cannulation themselves. That's how dedicated they are to making sure that that patient has a home after they go on ECMO. Here, you need to educate them on patient selection and the cannulation, because they're going to want to cannulate in a way that's amenable to your system of cannulation, often asking for advice on supplies, et cetera. And then also that immediate post-cannulation management, because they're going to have them for a few hours before they can get the patient to you. So they need to be taught on the critical care aspects of ECMO as well. The transport decision can be a little bit slower, or the process to get the patient transported can be a little bit slower, but that you really do need to train them then on how to take care of those patients for those few minutes or hours. And then they really are going to want a detailed discussion of cases in this scenario, because they want to know what they could have done better with the cannulation process as well as the transport process and selection. So this slide is my last slide, just to show you a little bit more, to be overwhelming with words more than anything. This is a sense of how many people or categories of people are involved in the transport process. In the middle is a picture of our referral centers for our center in Minnesota, reaching all the way to Montana, all the way to Wisconsin, south to Iowa, sort of regional. But each of these stars is an entirely separate model, whether they be the cannulate and ship or the ship to cannulate. It's a mix. And again, it's a mix for each modality within that center as well. So to be able to pull that off, you need to touch base with all of these people from across the system, from transport people, people at those hospitals, people at your hospital, people in your team. It truly does take a village to create a network that can pull this off. And it starts at home with a great ECMO program, which many of you already have, before you even reach out. And that's it. Thank you, and I look forward to questions.
So my name is Raj Ramanan. I've been blessed to be the backup moderator for this session. So if we have any questions from the audience, please feel free to step up to the mic.
I'm missing the aspect of organ donation.
Thank you for the question. Are we on? Yeah, thanks for the question. I don't know that there's a right answer. Oh, yeah, of course. So the question was about organ donation. If you have a questionable candidate for ECMO, and you don't know if they're a good person to anticipate survival or recovery, but to put them on with the anticipation that they might be a good candidate for organ donation.
First recovery, but it's not.
Yeah. The answer, I think, depends a lot on the individual system. So in the United States, it's different than it is in Europe. But what I think about is, one, I have to have a sense of whether or not that organ is going to be accepted for transplantation. Ultimately, that decision is not up to me. It's up to to UNOS, essentially. And so I have no guarantee necessarily when I put them on that they would be willing to take that organ for transplantation. So that's one thing I think about. The second is whether or not the conditions that got them onto ECMO are then going to preclude transplantation of that organ. The way I find this plays out most often in my practice is that often if somebody's on ECMO and their kidneys still work, they can transplant their kidneys. Sometimes they can transplant their liver. I have had, if it's heart failure, I have had the lungs get transplanted. Likewise, if it's lung failure, we've had the hearts get transplanted, but it's less common that they want to take someone who's been on continuous circulatory support for transplantation, and ultimately it's not up to me. So I think it's looking good going forward, especially with DCD donation, but I don't know that we're totally there yet.
Can I please, yeah, go ahead.
Hi, can you hear me?
Yes.
Okay. I just have a question when you're talking about patient selection. So I work at a robust ECMO center in Chicago, and we do about 130 ECMOs a year. And we often find ourselves in situations where we're not a bridge to transplant or a bridge to VAD, and not a bridge to recovery. But though that information is not known to us at the time of need for ECMO, especially in ECPR center or an ECPR center. So I'm wondering, to take it a step further, so often for us, we get patients anywhere from the amount of trauma that I'm sure you can imagine on the south side of Chicago, all the way through a very robust heart transplant and heart failure center. So when these patients roll in, we know they're young. Sometimes we know their downtime, and that's it. And so my question is, do your programs have criteria for bridge to decision, meaning that when we get there and we make the decision, and unfortunately many times the decisions that we're a bridge to nowhere and we have to withdraw, do you have anything built into your program, or have you heard of anything built into a program via a legal team that says we no longer think that ECMO is helping and it could be hurting and we can withdraw? Because then we end up on forever.
Thanks for the question. We do. It never plays out. It sometimes plays out better than I expect, and sometimes it's a disaster. We certainly will cannulate people, and if we don't know what we're going to do, because we think there's a chance, and we want to give that chance. I will say that it will have an effect on your overall survival numbers, and we, as an institution, have just said we're going to try and do the right thing, and to hell with the numbers. The problem then is what we'll generally try and do is have I'm an intensivist, so we'll try and have a frank discussion with the family when we're cannulating and we're saying we're going to do this for a time-limited period. And we may not come off. That works well when the patients are not alert.
Right.
The hardest situations have been when the patients wake up and we don't have a bridge off. And my N of a handful is that we then end up on ECMO for a couple weeks until things start to go south and everyone kind of gets worn down. And that's a really unfortunate and sad situation. We also have, we do all the things, but we also have transported to centers that also do all the things who might have different transplantation criteria than we do.
Okay, that's good too.
And we don't have ego about that. We'll find somebody we've sent across the country to the East Coast for transplantation sometimes.
Great. I appreciate it. Thank you.
Anybody else have any questions? Please feel free to step up to the microphone. Thank you.
Dr. Bartos, congratulations on leading the way in ECPR and ECMO transport. We, of course, all over are learning from your program. Now, can you share with us some of the early hurdles that you had to overcome when you started the transportation? And specifically, of course, that must have increased your ICU bed situation must have been impacted significantly. And can you share some of the experiences you faced?
Yeah, absolutely. Can you hear me? Is this one on?
Yes.
Okay, perfect. So, yeah, there are many hurdles, and they're the things you don't see coming usually, which are the big ones, like a pandemic, those sorts of things. ICU capacity is a big one. Once the answer is if you build it, they will come. That's for sure. I think, especially when you start talking about the region that you live in, they come from all over, and we rely on our criteria that we try to set ahead of time to be equitable and to be, again, predictable for our referral facilities. But I think one of the big initial surprises and hurdles is that you have, as Dr. Tono was saying, you have everybody calling you. It's not just folks in your hospital now, it's everybody in your state calling and asking you about this patient or that person, especially people that have arrests within procedures. So I think one of the hurdles was to say no to people that were deemed okay for surgery or for a cardiology procedure, a TAVR, for instance, and arrested in front of physicians who did therapies the right way, right away, but still say to them that this person, for a multitude of reasons, and it's never just one thing, is not a candidate by the criteria we've laid out to you before, and we will lay out to you again, and we believe is the best criteria. So that's the biggest hurdle, because that one tugs at the heartstrings. That one is where you're saying no to a person who actually may be able to live, but you don't know, and is somebody that you're also basically putting that terrible emotional outcome on the physician at the same time, who just did a procedure on that person that led to this event, or in some way it happened in the setting of that procedure at least. But that, I think, is just a reinforcement within your team, that the solution to that is reinforcing within your team that it's okay to say no, and that we're all on the same page and we're going to stick to the criteria. Other challenges, ICU capacity, absolutely an issue, and during the pandemic we did have to close down our program for periods of time. Even though I said over and over, don't say no, we had to say no. And that was even to people that did fit our criteria, and that has set us back as a program. Now, post-pandemic, we're going to have to recover from that. It has burned some bridges that I think everybody understood it was a pandemic, but still it's a problem. The supply issues, the things being on back order, when you start doing 5 ECMOs a day on some of these days, it burns through supplies quickly, and like having that extra supply and things on hand is a hurdle. So there are any multitude of hurdles and pitfalls, landmines, however you want to think of them, that you step on in the development of one of these programs. And certainly, as you have them, you're more than welcome. I'm happy to talk with any of you to help or to predict or to alleviate issues, but there are just so many. Thank you. I appreciate it. Great question.
Go ahead.
Hello. I also have a question about the team transport, team for ECMO transport, because I represent the Citizen Center for Heart Diseases in Poland, and for many years we used to transport with cardiosurgery, who cannulate the cannulas, cannula, because we are thinking that there is maybe this possibility to save the patients during any disaster during cannulation. But in fact, now we switch this position to the anesthesiologist only, because there's no time, in my opinion, we've done not so many than the previous speaker, but if I think about 250 during, not transport, 50 transport during the last 3 years. So in our experience, there's no time, and I think most of our patients, when somebody with problem with cannulation died in the hospital. So what is your opinion if you agree with me? So it's a very difficult situation, and no time for cardiology, for cardiosurgery, because this is a very difficult situation. So patient died.
Yeah, I think especially, again, most of what I do is ECPR. So if you can't cannulate them, they stay dead, I guess, effectively, because that's the way they're starting. But it's a high-stakes game, for sure. If you don't get them on, and if you can't keep them on, if you have a transport catastrophe, then the patient dies. And the question is, who do you staff that or go with that patient to prevent that or deal with it should it happen? I think with experience comes the ability to stabilize your cannulation to the point where you don't have decannulation issues, and that comfort comes with time. So at first, we started our program, our cannulations are almost exclusively done by interventional cardiologists. That's even true in our hospital. I am one of those interventional cardiologists, but I have other partners in the hospital that do it. And our transport team, or our people who will cannulate for ECPR in the field, in the truck, are also interventional cardiologists at this point. So we're very comfortable with cannulation, and we're very comfortable and able to work around some considerable vasculature to get people on pump. Once they're on pump, we secure it, and at first, for the first 2-3 years, we would transport with them, meaning the physician went along with. The more you see and the more you don't have issues, you build faith in your securement methods and the safety and the team that's transporting. Now we will transport with our cannulation assistant, flight medics and nurses, the dedicated teams who are specially trained and educated, but they are not the cannulators. And their training comes in the pump management. So they need to be able to, we all need to be able to cope with the immediate 1 to 2 hours afterwards, and that chugging and low flows, stoppage of flows, clots, things that can happen. And they're all still very trained for that and able to cope with it. So I think as a group that has experienced both models and both anxieties, I think we have gone through the phase where I would say it's safe to transport people without physicians, but the people still doing the transport have to be highly trained people who are able to deal with the issues that are going to happen during that time. But I commend you on working through, again, the anxieties, because it is very, very concerning.
So I'd like to thank everybody for their excellent questions, and thank you to this esteemed panel for your insightful talks, and we look forward to the rest of this afternoon. Thank you, everybody.